Okay, so when we talk about organizational characteristics, they want to know, are you for-profit, nonprofit but not government, or public-private partnership? As this questionnaire goes through, when you look at the handout, it's a little bit confusing because the web-based system, just like Amber, will use skip logic. If you answer no to a certain question, then there's other questions you won't even get. If you answer yes to a question, then you'll get questions that somebody else might not. And so as you read through there, it's got every single thing possibly listed, and it says, if you answered yes to section 1, question 9, then ask. So you have to kind of get through those instructions that when we get on the web-based system, you won't even see. So it looks a little bit more difficult than what it is. So just kind of keep that in mind. Some of them are questions you may not get depending on what kind of service you have. But in this category, they just want you to pick one. As we go through the different sections, then it will build on the questions that you're answering in this first section on your characteristics. Do you use volunteers? Right here is a yes and no. You'll get to report, if you use volunteers, you'll get to report more on that in a later section. But right here is yes and no. So, how do you define a volunteer? One of the things that AAA has worked really, really hard on is getting the definitions correct. When I talked about different agencies have to do cost reports every year, hospitals do them, et cetera, et cetera. Home health agencies had to do cost reports a few years ago, and that's the first time they had ever done it. They did not align as an industry, and they did not all say, okay, well, this is what a disposable medical supply is. This is how we're going to define, an initial visit. This is how we're going to define medical oversight, et cetera, et cetera. They did not do that. What happened is, Home Health Agency A got their cost report, and they filled it out how they thought they should. Home Health Agency B got one, and they filled it out like they thought they should. And so nobody's data matched because everybody defines things differently and everybody figures things differently. And what happened was CMS got that and said, oh, we're way overpaying you guys, because a lot of the data didn't make sense. And they cut their fees, their fee schedule, their payment rate, they cut it tremendously, and they still have not recovered. They still are not back up to where they were several years ago. And we don't want that to happen. So when we talk about how do you define volunteer, definitions are very, very important, because we need to all define things the exact same way. We need to understand when they ask this question, this is what they mean. And so this is how we need to answer that question based on the information that they are trying to obtain. And we've got some more other examples of that as we go through here. But as part of the AMBER and ambulancereports.org, there is a data dictionary that several of us have worked very, very hard on with CMS. We, Asbel and myself, I count myself one of the more fortunate things in my life is as this came up, we started back in 2008. I was 12 then. But anyway, we started in 2008 working with CMS because we knew this was coming. And we have been able to sit across the table, literally in the same room, with the people overseeing this project from CMS and provide them education. We've worked with the International Association of Fire Chiefs. We've worked with the NREMT, NASIMSO. All of us got together and have worked together to say, if you're going to get data from ambulance services, this is what you need to, this is the information you need to really understand how we do what we do. So definitions are very important. I'm going to let Asbel tell you the definition of volunteer because he can explain it way better than I can, because I think, does anybody remember Candy Stripers? Okay, I'm really dating. I was a Candy Striper for a long time, and to me, that's a volunteer. I showed up and I did stuff and nobody gave me a paycheck. I did it to get volunteer service hours so I could go to a good college. But that's not how they define volunteer.
Yeah, and we will kind of when we start talking into the labor cost or whatever with volunteer, but on an aggregate, which means on a yearly basis, if your employee is not making minimum wage, then you're going to be a volunteer, or that employee will be a volunteer. So for instance, some people will pay a stipend for somebody to be on call. For 24/7, you'll get a stipend, and then if you actually get a call, then they'll pay you while you're on that call. the hourly wage, but on an aggregate, if you're looking at that over a year, and the stipend that you pay based upon the time that they were on call, then the hours associated, if that general rule, so say for instance it was $1,000 for that year, but they were on call for 100 hours. Your 100 hours divided into your $1,000, if it's less than the minimum wage for your state, will be, which whatever your law is, then if it's less than that, then that's a volunteer. If it's at least minimum wage, then it would be considered paid staff and not volunteer. So when we go through labor, we'll kind of walk you through that piece of it, because some people just think, well, I'm not a volunteer agency, or volunteer's not in my name, so that means I don't have volunteer. That doesn't necessarily mean that, because there's so many different models that are going across the nation or whatever. So the general rule of thumb is, if your employee did not make a minimum wage, then it more than likely, then that is a volunteer employee. So you could be a township or something like that that's not necessarily a volunteer fire department, but you're utilizing some staff that might be considered like volunteer staff, but if their wage that they got on the aggregate was at least minimum wage, they would not be classified volunteer when we start going through the labor, and I'll kind of go over that in detail as we walk through labor. But that's kind of your general premise if you are a volunteer. And so you'll want to click yes or no on that, because then it's going to take you through, because we have to make sure
This is
that
why-
we're using apples to apples.
That's why it's important, because if you answer no, because you don't think
It
you
will not
do,
ask those
you're going to
questions.
miss all those questions. That's going to really skew what it really costs to do, to provide the service there, because you're going to miss out on being able to report your stipends and your honoraria and all of that stuff that's a true cost. So that's why it's important in this one, even though it's a yes and no question, understand what they're asking so that you will get the right questions later on in the instrument. Yes, ma'am.
What if you function with both? You have full-time employees that make minimum wage or above, but then you have some that do not.
Right, then right here, you're going to say yes. And then
So if
later
you
on,
have
it will
one
ask you.
volunteer employee, say yes.
Okay. Yes, sir.
So what if that changes throughout the middle of the year?
It's
Because right
wherever
now
you
we're
were at the beginning of
volunteers.
your reporting period.
And we'll go through that. There's several places where it says at the start of the year. At the start of the year. So everything is based on, like when he gets into the labor costs, how you categorize your different staff, it's where they were at the beginning of the year. And he'll go into that further. So, okay. What category best describes your operations? Are you fire department, police, or other public safety? There's other questions based on how you answer this question. If you say, yes, I am fire department based, then you'll get questions that I might not. So are you government standalone, hospital, or other Medicare provider of EMS? So I won't get into that. Independent proprietary, primarily providing EMS. Are you independent and mainly doing non-emergency? Other. And that will give you a free text box to how you categorize yourself. So do you have shared cost? This is one that gets a lot of people, because you need to understand what a shared cost is, because you will not get the questions you should get if you answer no to this. The shared cost, if you said you were fire department, police department, hospital, confirm that you share some of your operational costs, like your building or personnel. Yes or no, we share some or all of these costs. Most fire EMS are going to fall under a shared model. Okay. What if you are a government standalone, but county clerk does your POs, or the city does the HR portion? That's also a shared cost. So understand what they're asking when they ask this, so you'll get the right questions. Or, if you're not police, fire, or hospital service, do you share operational cost with a fire department? Now that seems like it's the same question, but it's not. What if you're like the smaller service where I came from, we were a third service. We were an entity of the county government, and I would have normally said, no, we don't share costs with the fire department. But then when you look at it, we oversaw all of the EMRs that were fire departments, and we provided training for them. They provided some of the labor for us, and so there was a sharing of costs that you don't normally think of. So this is a different question. Do you have an air service? The service that I'm with now has an air division. So if you answer no, you don't have any kind of air service, then there'll be a section of questions that you don't answer that I will have to, based on how my costs on this MPI are shared across the parent company, are allocated to this company, how much is allocated to the air service. So, and we'll work through that. Or no, I don't have any shared costs with anybody. So, then it wants to know, do you routinely respond to 911 calls? Yes.
Oh, sorry. So you say shared cost, so what if you're actually not allocating the cost, but you are supporting it? So, for example, I pay all the invoices, and that includes some of the EMS invoices, but accounting-wise, I don't get paid by the firemen.
So when we go through the cost, this is an area that you are going to have to set up in your systems going forward, how that cost is allocated.
So we will have to.
So you are going to have to do that. So if you
What was,
answer
will you
yes.
say the question again?
Oh, I'm
So that-
sorry. So her question was, well, what if right now, we share costs, but I don't currently get paid from the millage, but I'm doing all the processing for all the fire invoices or what have you. Is that your question? So you are going to have to kind of understand what that cost is. So if you currently do not know, you're going to have to set it up, get down to understand the allocation of that. So if you're a fire department, if you're a police department, if you're something that shares services, especially this is very common on a county basis where maybe a finance department's running X, Y, and Z, you need to understand what that cost is, even if it's just a transference on your P&L. There's no actual money exchanging hands. We need to understand what that cost is. So when we're comparing apples to apples, you're not underreporting. That is our biggest concern, is that the cost will look like it's cheaper to run the service than it is because we're not using those allocations. And we're going to go through that when we really start diving deep into the cost, because you're going to have to go back and really set your systems up accordingly. Somebody had a question?
There's a shared cost, like our pharmacy boxes. With state of Michigan, what I understand is the hospitals will restock the box. They accumulate the cost of the pharmacy product. We pay a restocking fee, so is that considered a shared cost?
So that's a little different. There is a way to kind of work through that process on that. That would not be a shared cost in that, but there is a way to allocate the restocking fees under cost.
Okay.
Shared costs are going to be more attributable to, if you think about like your finance functions, your HR functions, your maintenance functions, different things like that. When we dive deep into it, that's where dispatch services,
building.
different things like that.
So, okay, then they want to know, do you routinely respond to 911 calls? Do you have land-based ambulances? Do you operate water-based ambulances? Definitions matter. The definition of a land-based ambulance is what is licensed in your state as an ambulance. So, and then water-based, it's not going to be, and a lot of fire departments have the boats and stuff that they do water rescues with, but if it's not licensed as an ambulance, then the answer is no. Now, you will get to account for that in a later section, but in this question, if you don't have a boat or a water rescue vehicle of some kind that is licensed as an ambulance in your state, then the answer is no. Does that make sense? Okay. Do we have any licensed water ambulances here? I ask that every time, and nobody has said yes, and I'm so disappointed. I really want to find somebody that says yes. We have a boat that's licensed. Do you operate air? Yes or no? So.
We've got a lot of flooding in the south end of our city. Our ambulances go through that.
That is, you know what? I think if the tires float, then you should look at your state to see if you can get cross-licensed as a boat. I get it. So, and then they want to know what deployment model. Are you static? Are you dynamic? Are you combined? You know, static is like a lot of county services, a lot of fire departments, it's 24 on, 48 off, or 48 on, 96 off. You know, you have the same number of ambulances with the same number of people day in, day out. Dynamic is your staffing changes based on statistics, based on your call volume and the day of the week and the month of the year. And, you know, sometimes you have more because you have tourists, you know, from May to August, and so you up staff, and then August through, you know, April, you have less, or like maybe on Sundays it's a low call volume day, so you don't have as many. That's a dynamic. And then some places have a combined staffing model. So, Do you provide 911 services around the clock, primarily, meaning in most or all of your service area, your primary service area? Do you perform paramedic intercepts? I need everybody to pay attention. If you are licensed in Michigan, the answer to that question is no. Everybody understand that? No. The answer is no. Paramedic intercept is a definition, it's a term of art used by CMS, and there is only New York State that qualifies for a paramedic intercept under this definition. Now, if you ask me, do I do paramedic intercepts, I'm going to say, yeah, of course we do. You know, we get smaller services that call and say, hey, we got a full arrest, you have a paramedic that can meet us, and the paramedic gets on the ambulance, and they run the code, and they go to the hospital. To me, that's a paramedic intercept. That's a common everyday usage in our world. That is not the definition for Medicare. So
technically, if CMS had been smart and listened to us, they would have just said, if you're New York, say yes. If not, say no. That's what they really should have said, but that's what we're trying to tell you.
Yeah.
To this question, if you're not in New York, say no.
So other than the paramedic intercepts, do you ever deploy an ALS emergency response staff as a joint response to meet a BLS ambulance? They want the ones that you do not bill for. Because if you do this, but you're the one submitting the bill, then you're going to account for that in a different section. They're trying to understand how many times do you send out an ambulance, an ALS ambulance, to help a BLS ambulance that you do not get paid for. So.
Even if we bill the other organization, we're not billing Medicare, but we would bill the other organization.
So you would say yes to this, so you're obviously responding to a BLS only, is that correct?
Yeah.
So then yes, you would say yes, and then that's where it would then prompt you to ask some questions. Okay?
Then you can
So
say
if
how you're getting
providing-
paid.
If you're a paramedic service and you are providing basically a joint response for a BLS only service, you'll want to say yes to this because you probably have a contractual agreement between them to send a bill to them for the service. That's typically practice in our industry. That's what we're trying to tease out. So you say yes to that, and then it's going to prompt you through some questions. If you say no, it will not prompt you through those questions, and you do not get credit for that cost because theoretically it's a readiness cost. And where we're trying to get back to the cost of readiness, like most people talk about, we've been trying to say it, our payment schedule, our fee schedule doesn't incorporate cost of readiness, so you're not going to see something that says cost of readiness, enter a dollar amount here. This is where we're trying to get at some of that, of those questions that you see here is a cost of readiness question. So if you are providing a service, paramedics to like a BLS only type service, and you are not billing for that, you would say yes here, and then it's going to prompt you through. Does that make sense?
Okay.
I think this is going to be the most confusing question that is going to be on the data reporting tool, so you may forget through the process. AmbulanceReports.org. Call. We will help you through this to make sure you're defining it correctly.
You guys are asking some really, really
Yes.
good questions. We have 13 sections. We're starting section 3. We're going to have to speed up a little bit, but everybody's looking a little restless. Do we need 5 quick minutes? Or you want to power through and just go as you need? Okay. Service area. What are the zip codes in your primary service area? And they're going to explain what's a primary service area and what's a secondary service area, because that's what they're asking. The primary is the area in which you usually provide service and where the majority of your transports occur. Secondary is where you provide service area under mutual aid or auto aid agreements. That's your secondary service area. They don't want the exceptional hurricane, send a truck, 400 miles over to help somebody else in the state because they've had, a city block catch on fire. They want your ordinary, average, everyday, what's your primary service area. It'll be a zip code that's a drop-down list. You can also add, if your zip code's not on there, then you can add additional zip codes for primary and secondary. Should also be listed on your 855B, your service area zip codes. That's another area you can look at updating. And then they want to know what's your average trip time. And this is important because I want to tell you this so we all get the same time. The trip time is, because they've got it they got the definitions in a different section, which I think is really kind of weird, but the trip time is from when the ambulance leaves. Let me tell you the right time. Do you remember?
So your average trip time is going to be from the time your call comes in to the time you're back in service.
Yes.
Okay? So really, if you just get to the average, because if you do a lot of long distance transports, a lot of times that can skew the number. We did not think, and when I say we, it's the American Ambulance Association, really this was to try to get at what people think is the cost of readiness. But there's other ways to factor that in. This is a very subjective response. It doesn't really paint the picture, because I could do 5 long distance transports and go 400 miles, and it takes me 24 hours, and it can skew my average response time to being more than 150 minutes, but it was really for 5 transports. So it really isn't telling me anything much. And there's other ways to get up the cost of readiness, but the industry, when they did a lot of the stakeholder engagement, really wanted this, really wanted this asked. So to be honest with you, I really don't care about it, because it is so subjective, and unless you really get down into the weeds and try to really understand, and you ask certain other questions around it. So my standpoint is, as long as you just use on the aggregate, what's your average time that your call comes in to the time you're back in service, and we'll kind of walk through that as well. That, wherever it falls in your A, B, C, D, E, and E, you just pick that.
Yeah, you don't have to get to the exact minute. Yes.
When you say when the call comes in, do you mean when the call comes into dispatch, or when dispatch dispatches your ambulance?
Because that can be completely different
So
times.
remember, this is emergency. So it's when your call comes in until you're actually whatever. So they're making the assumption on non-emergency. Remember, this is emergency only. So when your call comes in, so if it comes in at 13:51 and you dispatch the unit at 13:57, you should start at 13:51, and then you're back in service for a new call at 14:49 or whatever. So your 13:51 to 14:49 is going to be your response, or your average trip time. And then you would take that on an aggregate for the year and kind of work it through. And is it on average, is it taking you 121 to 150 minutes? On average, you would put number E. But as you can tell, there's so much that goes on in those pieces or whatever that it really lets you finite it down. I mean, you're going to have to ask several more questions to this, like how many long distance transports do you do? How many do you do every month? Because then you need to weed that out for it to make sense, or this is so subjective, what does the data tell you? Really nothing, folks, and we got to dive deeper into for the cost of readiness. So as you can tell, I'm kind of jaded about this dumb question, like we wanted to get it out, but unfortunately what RAND came back, who was the corporation, they said, we heard from so many stakeholders that they wanted this in, that we get it, we understand, we agree with you guys that this is not going to tell you anything that you really need to know from a cost of readiness standpoint, but because many of the stakeholders wanted it, this is what it's in for. That's why you don't see a lot of information teasing it out to our granularity, because for it to make any sense and to be meaningful, you need to really ask many more questions regarding this, if that makes sense. So I'm just trying to tell you, don't spend too much thought into this. Use the general, get it out of your CAD system. If you're still doing cards or still using Excel spreadsheets on that process, just get down to the basics to be able to substantiate why you picked your number that you picked.
This one, it says from the time the ambulance leaves the station to when the ambulance is available to take another call. That's how they define this, and it's different from response time. That has a different definition. So the main thing on this to keep in mind is if you have long transport times, don't forget, it's not when they are cleared from the hospital. If you still have to go 45 minutes to get back in your service area to be able to take another call, include that time. That's the main thing about trip time, is don't cut yourself short. Yes.
Is this for transports only, or is it across all responses?
This one's
It's
for transports
transports.
only. There's going to be another where you look at response.
Yeah. So do I have one more question? No? Okay. So, and then it says secondary, wants to know the same thing, your average trip time across your secondary levels. Then we get into emergency responses. The first question is, can you report your organization's response time for ground ambulance in your primary service area? Can you even report this? And if you say yes, then they want to know your average response time, and it's figured pretty much the same way. And then they say, if you say no, then they want you to estimate what the average response time is. So then they want to know response time targets. Do you have those? Do you get penalized if you are not meeting response time targets? A lot of people have response standards that they have to meet, the 8 minutes and 59 seconds, those kind of things. And if you have those, who sets those? And if you have them and they're set, are you penalized? You don't put the answer to that. I mean, you don't say what the penalties are here. That's another place.
That's probably the only important thing to know that's going to factor into your cost. So if you have a response time where you are penalized, if you don't meet a 6 minute and 59% response time 90% of the time, then you receive a penalty or a daily penalty. This is about the only importance to this question, because it's going to drive into what those penalties will be, because it will increase the cost of providing the service. Other than that, this response time piece of it, again, it's the same thing with the trip time. It's not really teasing out the cost of readiness. There's other ways when we get into cost where we're going to tease out what that cost of readiness is that should be buried in your cost of labor and all this other stuff. Does that make sense? But if you've got response time parameters codified in ordinance or statute that penalizes you if you don't meet them, you need to make sure you pick yes here. And then that drives you into other questions in the intuitive tool. Somebody had a question.
I know we can get real deep in the weeds on a lot of these questions, but one of the things is, as far as the times go, the dispatch times, if there's a discrepancy between the actual time dispatch and the time that you get reported to you, which times are we going by? Are they gonna, is there a point where somebody's gonna check up and say, wait a minute, this doesn't match up with what you reported?
Well, it says response time is the time from when the call comes in to when the ambulance or another EMS response vehicle arrives on scene. So how you want to define is when the call comes in.
What's actual the time? Does that make sense?
Yeah, so intuitively, I'm just going to say, be able to have your reporting substantiate what you're putting in general. So like I'm telling you, I wouldn't read way too much into it, because I'm just telling you from what CMS's perspective was. They didn't want to do this anyway. It was basically because they knew that there were so many nuances in it, and it wasn't going to tease out the cost of readiness like the industry thought it was going to do. We can actually get it somewhere else. So as long as you can substantiate what it is, I wouldn't use your system the way that your system is right now. And if you've got something, I wouldn't spend much time on this. I'm not trying to make it, I wouldn't spend much time on this. The only thing that I care about really is the penalties. If you are penalized for your response times, if you don't meet them, it's important to know that.
And there's a place further on in the cost section to report that. So then they want to know about the volume, because you remember that's one of the 25% stratification that they chose is the volume. What kind of service volume do you have? The number of responses with and without a ground ambulance. Okay? The number of ground ambulances responses across all payer types and across all service levels. So you've got your number of responses in total, whether or not a ground ambulance was deployed, and I really truly think that they are trying to get how many requests for services are you responding to, you know?
Now, these are the numbers that are going to tease out your cost of readiness. This is more important than times. This right here. So if your system cannot tease this out right now, which is typically in your CAD system, there's still people on paper systems, it's any response that comes into your system.
Whether or not the ambulance gets on scene or not.
That is correct. Okay, remember, that's what we've always said, is right now we only get paid based upon a transport. So if we're going to start teasing out, we've got to be ready all the time, and we get multiple calls sometimes where it might be a false call, but it's tying up resources. Or we may have dispatched an ambulance and then it got rerouted or it got canceled 3 minutes en route. That's what we need to begin to tease out in volume. This is where cost of readiness is starting to come in. Now we can start to quantify it. So if your systems don't currently capture that, Your systems need to capture that. You need to audit your systems, make sure your dispatch is getting every call that comes in. This is how you're gonna get at cost of readiness.
Okay.
It's one of the mechanisms that we're gonna get at it.
So then they want to know how many ground ambulance responses across all service, it doesn't matter what the service level or the payer type, just how many ground ambulance responses, how many of them in your secondary service area, and then they want to know how many there were no transports, and how many received treatment on site. Which again, when you look at it, you're like, why are they? Because it has to do with cost of readiness. It has to do with calls that we are not currently getting paid for through Medicare.
What's a second service area?
So your second service area is basically anybody, if you have a mutual aid or auto aid agreement, that is the second service area. If you do not have a mutual aid or an auto aid agreement, it is always your primary service area. That's the simplest way to talk about that.
Okay. And then it wants to know how many ground ambulance transports. Now keep in mind, a response, ground ambulance response, and a transport are not necessarily going to be the same thing. You get a ground ambulance on scene, that's a response, but they didn't transport anybody, so that would count as one response and no transports. How many transports did you have? How many patients were transported by your service? How many times did you get a request for service? How many times did you transport patients? How many patients? Does that make sense? How many of those were paid? Does not matter if it was partially paid or all the way paid or paid by Medicare, paid by the patient, paid by a third party. Doesn't matter. If they were paid at all, it goes in this category. And then they want to know, do you do standby events?
This is everyone, not just my medical.
No, this is everybody. Okay. There's a place later to report revenue by payer, by Medicare, and then how you allocate that out. But in this section, remember, we're just trying to figure out who you are as a service and what you do. Yes, sir.
So if you split your primary area with another agency.
That's
it's not
fine.
affiliated with you, can you still use
Yes.
that zip code?
Yep.
You can have multiple agencies having the same zip code as their primary area.
Okay.
So in a lot of big cities, that's really common to have multiple services that all consider these 8 zip codes their primary service area, and that's fine.
Just make sure your primary area matches what's on your 855.
Wait, hang on.
Going back to
Let me
that.
get him back there, and then you. Go ahead. Do you have a question? No? Okay, go ahead.
Patients who should be paid transports, but they end up being sent to collections.
We've got that question before. They're not paid.
But they're sent to collections.
Yeah.
So you're going to look at paid transports. If it's zero, if you have zero money on it, it is not a paid transport. Doesn't matter.
That's
We'll go
kinda
over the
the-
revenue on the collections. Remember, this is actually going to inure to our benefit because it's always been our complaint that we do a lot of transports we don't get paid on. This is what that's teasing out. So if you do 1,000 responses and you only get paid on 400, that actually is good
Hang on.
for our industry.
I got one over here, and then I'll get you. Yes, sir.
So we're a BLS provider. We respond with our ambulance, but the county has contracted the services through millage for an ALS provider to also respond every call. They do the transport. So are we putting down that we're responding with our ambulance?
Yes, you are responding.
And we would have a zero transport because of course the ALS provider.
Right.
Correct.
So you might have 100 responses and 30 transports. So we're going to get at, that's part of your cost of readiness. There's also going to be in there where there's a contract between that as well, so there's a joint response. On their end, they will be doing the billing, so their joint response will be no. Yours will be yes.
Right here.
Yeah, under the total responses, it said if more than one vehicle is sent to the scene, count this as one response. Why is that?
Because what happens is, like, let's take an example of two vehicles in a car crash, okay? And they call and say, hey, we need an ambulance. And you send a fly car, you send a rescue from the fire department, you send an ambulance. It's still one response because it's one request for service.
So even if we have more than one ambulance there, it's still one response?
One response. Now, let's
Yeah.
say the first ambulance gets there and says, oh, we got 3 patients, I need another ambulance. ideally that should trigger a different call, which should be a second response.
And a second M. So you may have to change the way that you do things in your system. So theoretically, what Medicare expects you to do, which you should have already been doing from eons ago, don't admit if you haven't, but this is the assumption that they're making, is if you do a response and you send out 5 ambulances to a motor vehicle accident, that's one response. If you get on scene and you've got to transport 3, theoretically, you should be generating another incident and 3 incidents. What you should be doing. A lot of people do not do that. You need to rethink your systems to make sure you're accurately reporting. So theoretically, what you should be doing is now I've got 3 responses, 3 ambulance transports, 2 fly vehicles, or whatever like that, and we'll record them elsewhere. So you're going to have to rethink, the industry is going to have to rethink how they do that, what we call incident reporting.
Then they want to know what percentage of these were paramedic intercepts. And for everybody in this room, the answer is what? None, 0. And then how many are joint responses, the ALS, BLS responses? You're going to have a lot. So, and they want to know about your service mix.
Yes. Question here.
What if you go to a car accident and you call in extra people because you've got multiple patients and you need refusals? Should you get a separate number for every refusal?
No, I would get a separate number for the ambulance that came out.
Okay, even if they just get refusals?
That is correct.
Okay.
So, okay.
You'll still have one response, but then you'll have multiple treat no transports, basically.
Okay. So, yes, sir.
Did you also, you may have said this already, but what interfacility transfers, is this included in this?
Interfacility transports, they are.
That's a response, okay.
That is a response. Let me see.
It's a response plus a,
Yeah, right here. All of your calls are gonna be categorized into what they are, and then out of that, you're gonna categorize how many of those were interfacility, okay? So on your service mix, how many are emergency, how many are non-emergency? Should be 100%. That should equal 100. And if you don't know, this is a good time to start collecting that data. How much are emergency, how many are non-emergency? You know, before you have to go back and count every single call, set up your system so that you can categorize that and pull that number.
and this is responses. This cannot be pulled out of your billing system. Okay, now there's gonna be another that's gonna ask you for transports. This is responses. So unless you bill for every response to generate revenue, your billing system is not where you get this number.
Yeah.
Just want to make sure people understand that.
That may be a different
Because you'll
report through
underreport if you do that.
dispatch system or something, your CAD system may be able to pull it, so. Then they want to know how many were land and how many were water. And again, that goes by licensed water ambulances. So theoretically, everybody here should have 100% is land. So then they want to know the transport type, the percentages, and keep throughout this instrument, some things ask for exact numbers, some things ask for dollars, some things ask for percentages. So another good reason that Amber is going to be a good tool to help with that if you elect to use the Amber software is because it's not going to let you mess up and put a percentage where you should have had a number. So,
And this should be pretty easy.
Yeah.
This should come out of your billing program, folks. If you've got a billing agency, they should be able to pull this report pretty good. It's a standard report. This is going to be an easy
Yes, sir.
report.
So, for instance, our department's a BLS transport,
Mm-hmm.
but we always have an ALS intercept. Now,
So do you bill the ALS?
Do you transport?
we do bill the ALS, but if the medic deems that BLS, then we bill it BLS.
Correct.
Transport BLS.
Correct.
So back to your couple previous slides, you said something about the ALS intercepts.
Mm-hmm.
How
So
would
the-
that apply for us?
So the joint response, you bill for the ALS?
Yes, sir.
Okay, then you would answer no to that. What they're trying to tease out there is for those that do not bill for it. You see what I'm saying? So if you're providing the ALS response and you're billing for it, then you're not going to do that because it's going to pick up here. So you would answer no to that. If you answer yes to that, where you're the BLS entity, but say for instance in your situation, you're billing somebody else for your paramedic intercept, then she's going to say yes because then there's going to questions they're going to ask, how many of those do you do? Because Medicare, you're not billing the Medicare program for that. or any payer for that. Does that make sense? But if you're billing a payer for the ALS because somebody jumped on your ambulance and you're the entity that did the destination transport, then your billing is gonna show up in here because you're gonna have ALS calls. Does that make sense?
Yep.
If you're not, because you're not the internet, then you need to answer yes, so it then intuitively will start to ask you other questions on how many you do.
Okay, so when we talk about interfacility, they want to know how many patients are inpatient or SNF that are not separately payable under Medicare Part B, and how many are interfacility across all payer types.
So how many people do IFT transports in here? Or interfacility? So there's a few of you. Well, there's a lot that do interfacility. So you'll need to understand the difference. Those are those what they call Part A stays that you might bill the hospital, the DRGs. You'll have to know those, and then you'll have to know the ones where Medicare pays separately.
So if you can't get that data now, this is a really good time to set up your systems to be able to pull that or to set up a mechanism for you to do that.